This is Tell Me Exactly. I'm your host, Meredith Jensen. And today I have two returning guests who are always some of my favorites to sit down and chat with. I always learn something new and appreciate their knowledge and experience. Joining me today is Louise Todd and Brian Dale. Thanks again for coming back, guys.
Thanks for inviting us back.
Thank you.
So, Louise, tell us a little bit about yourself.
So, my background is being predominantly medical in the ambulance service field in the UK. My career started as a dispatcher. We were known as control assistants way back then.
And what do you do for Priority Dispatch now?
I am the Director of Operations for UK, Europe and Australasia.
All right.
So I have a team of people that
Boss
work for
babe,
me.
I love it. Boss lady. All right. And Brian, for those that may not know who you are, let's tell our listeners a little bit about you.
My name is Brian Dale, and I am a fire and medical and Q subject matter expert. Background in fire and EMS since 1983.
All right. Thanks for being here. So today we're telling you exactly what you need to know about how the UK ambulance service is evolving over many, many years. So Lou, I'm going to start with you. I understand that the transition that we're kind of going to dive into today goes back something like 40 years. That's a lot of ground to cover. But what are some of the changes and evolution that the UK ambulance service has gone through over that time and how it maybe impacts what you're doing today?
Okay, so when I first joined the ambulance service, it was way back in 1986. I'm coming up to my 40th year anniversary in healthcare. I'm very old. It was really very different to what it is today. When we first started, we were known as control assistants, and that's literally what we did. We answered the emergency calls and the urgent calls. We were very much a manual system. No computers. It was pen and paper.
Yeah.
Map books. Everything was analog, and the way that we kind of managed where our crews were through the radio system and a system that we would write on a board. And to remove that information on the board we used methylated spirit. So I'm just going to leave that right there.
Yeah. For those young kids out there listening, they probably have no concept of what we're talking about right now, right? What? There wasn't a computer to do all of these things?
Completely, pen and paper. During that time, though, we were in a transitional stage there where we'd moved from very much town-led ambulance services to county-led ambulance services. So when I first joined, we were then known as an ambulance service, which was the name of the county, and it covered a bigger area. The other thing that was really exciting happening at the time was Dr. Peter Baskett was introducing paramedics. And
the actual first versions of what a paramedic is.
Yeah. And so we had paramedics very early on in our ambulance service. Of course, that's evolved over time. Now they are, they do a paramedic science degree. So it's a degree-led 3-year course. And, very much for me, my role was in the dispatch center, in the control. We called it a control room, control center then. And as I said, we were there to process the emergency and urgent calls. I think for me, seeing the evolution over that amount of years is really kind of amazing and fundamental. I guess just thinking back over my career, as we weren't, anything was nothing electronic, but then we did introduce computer-aided dispatch. We did introduce MDTs and tracking systems and mapping systems into our world. So we went from a very manual process to the very early dot process CAD systems and mapping systems. And then came the introduction in the mid kind of 90s of MPDS into the UK. That again drove so much change. So we went from a first come, first serve basis to now we're triaging the emergency calls. And so no longer are you in this stack of, if I cut my finger, I'm going to get, and there is a cardiac arrest, we're going to go on the cut finger first.
Right.
To
Because
actually,
they were the first ones in line, right?
exactly, triaging those emergency calls. And alongside that was quality assurance, which was a massive driver for us. And we became ACE, implemented in 1999, became ACE in 2001. And my chief exec at the time told me that now he could sleep at night because we were one of the leading ambulance services in quality
Right.
in the UK and ultimately in the world, really, at that stage.
So, Brian, talk a little bit about maybe from your perspective how that compares to the changes that you've seen over the years stateside in the U.S.
Well, I had a conversation many years ago with a good friend of ours, James Gummett from London Ambulance Service.
James.
And
Shout out to James.
Yeah. And we were talking about the load, and we were talking about how the UK expects the emergency dispatcher to be so exact with the specificity of the code. Delta 1 or a Delta 2, in most systems in the US, that's a big red truck and an ambulance. In the UK, one may have to wait for 45 minutes. It's that specific. And we were talking about it, and he said it's not that different. In the United States, you see a lot of people who don't have any resources. They may not have money for a taxi cab, they don't have a doctor, and so they call 911 out of, not frustration, but out of a real need for medical care. And there's an impetus in the United States for transport. The ambulance that shows up wants to inherently transport you because that's a fiscal reality for them to be able to capture fee for service, right? In the UK, it's different with the same outcome. They pay their taxes, and that's part of what they get for those taxes is, all their medical care and emergency transport. And so they're calling and overloading the system not because they don't have resources, because they expect to get the resources that they paid for.
Right.
So we end up in a very similar situation, except, and I know Louise will highlight this, there is an impetus in the United States to transport. There's an impetus in the UK to provide care. What that means, and if you listen to her talk about the endpoints that they have created, being able to be transferred to a pharmacist, and the pharmacist will prescribe medicine, right? And so the ambulance is just one avenue, and even though the ambulance may show up or may not show up, it's not there to transport. It's there to get you the treatment that you need. And that could be alternative care, it could be what they call a clinical hub, any number of things. And the United States, we should be doing that, and agencies have tried, my own included, except there's not a lot of, we don't have those alternative resources like they've had to develop in the UK. And it's a marvel to see their system, even though they're so busy. And they may have to wait a protracted time to get an ambulance to come to your house. But the reality is they have so many other avenues they can use to get people care. It's that same old thing. It's, it's out of mandate or out of they're drowning in people calling for assistance, they have revolutionized or evolved to a different system, and it's pretty impressive to see.
Yeah. So, Louise, you talked first about all the changes to technology, that's a global thing that we've witnessed over the years, right? Like everybody started on paper, even, anywhere on the planet, and now technology has allowed us to evolve over the years. But now talk a little bit about what some of the more recent changes have caused that kind of shift to healthcare providers instead of just responding, like Brian kind of spoke to, right? That there's that expectation to provide care more than just, I guess, essentially showing up, right? And dropping you off somewhere else. So speak to that, if you don't mind.
Yeah, so we have moved from, we're still an emergency service. We still provide that emergency response to those patients that need it. But our health system is quite overwhelmed with the amount of calls that we receive, Yeah. In the UK, we have one of the busiest ambulance services in the world.
So let's break that down. What are we talking here?
We're talking
Numbers.
8,000 emergency calls in a 24-hour period.
Yeah.
In quite a small, quite condensed high population, high transient population, but we are in that 24/7 environment now. And I think people expect that immediate care. So they're not just calling in for if you've got chest pain or those more serious conditions. They're calling in for maybe some social care, or they're calling in for more minor ailments that you would normally see your general practitioner for.
Right. And when we're talking 8,000 incidents per day, to be clear, we're talking just medical.
Yes.
That's not fire calls.
Absolutely.
That's not police calls. That's
Absolutely.
not admin calls. That's 8,000 emergency medical calls.
Yep.
Yeah.
And that equals 1.6 million 999
That
calls
was some really
per
quick
year.
math. I'm impressed, Brian.
That number stays in my head
That's like
forever because they
Goodwill
are
Hunting level
they are
math.
Priority Dispatch and the Academy's largest client. I
Yeah.
mean, 1.6 million calls per day. Their dispatch center is over 3 floors. I mean, it's 3 different floors.
Yeah.
It's an amazing place to see, and they're doing a lot of hard work.
And even that is our busiest, but even our other services, you're still talking 3,000-4,000 emergency calls a day.
Right.
So we are busier. Even before I left the ambulance service, we were talking of a 6% year-on-year increase on emergency calls. Well, that's tripled.
Right.
And I think the system becomes overloaded because you cannot possibly respond to all of those incidents.
Yeah, you don't have anywhere near that many ambulances
Exactly.
or staff to even respond.
Yeah. So some of the initiatives that there was introduction of, 111 systems, healthcare systems, where that non-emergent had another number to call to get that more in-depth look at what their needs were and to try not put them into that emergency system. Within the ambulance services themselves, they set up clinical desks. So you'd have paramedics and health advisors in their dispatch centre to really look at those lower acuity calls and try to get them out of the system.
Right.
It wasn't a question of we're going to respond to everything. It's like, well, what can we do? What is our alternative care pathway for these patients? And that might be you're going to pharmacy. It might be you are going to book an appointment with your GP. It may be other avenues. It may be simple. Well, we're going to monitor your situation. We're going to call you back in an hour.
So I'm curious, how was that received by the population at that time? Did you have people that were frustrated that, no, when I call 999, I expect someone to knock on the door and have an ambulance waiting for me?
I think there's always a level of frustration, but it's it's the education piece. Yeah. It's about the educating your public, educating your responders, educating your dispatch center staff, and then how you handle that when you are questioned. I mean, of course it happens. It still happens in every day where people will ring back and they're frustrated because they haven't got what they're expected. But a patient journey for a 999 isn't just about getting a response. The patient journey is about what else can we do while you are maybe waiting?
Right.
Because we have some serious wait times. And it's about then, well, you're going to be touched along the way. So it may not be physically, but it's going to be you're going to get a call back.
Right.
A paramedic is going to call you back, or a nurse is going to call you back, and we're going to explore. We've done the MPDS triage, but now we're going into the secondary triage. Now that could be ECNS, it could be another provider, but now we are going to explore that. We're going to go deeper. We're going to really find out what your healthcare need is. And then we're going to send you in different directions. It may still come back as an ambulance response, but it may not be that immediate, you must go now.
Right.
There may be like a different level and a different tier on that.
Okay. And so what was the immediate impact to your response when that rolled out? I mean, we talk about maybe there was a little bit of frustration from the citizens because they didn't understand. They had always expected something else when they called 999. And I imagine over time, eventually the word gets out and you have enough personal experience with something when you call 999 that now you start to kind of understand and know that no, maybe there's these other steps that are going to happen. But what was maybe the first big wins that you started to feel when you were rolling out that program?
I think when I was in my agency, and we're talking really early days here with NHS Direct, okay, it's far more than it was then. But we would save a day's worth of activity in a month, which
Wow.
it doesn't sound that big. At the time, we were probably dealing with maybe 200 calls a day, 300 calls tops. You know, New Year's Eve, it might be 600 calls, and we thought we were really busy. And when I think now, we were so not busy.
Right. But that was before cell phones.
But that was
Yeah.
saving a day's worth of activity in a month. So even those early figures were actually having an impact. What our system now is, it's not always about responding, it's about responding and providing the most appropriate care. Now that might be you're going to have an ambulance. It might be you may have a single paramedic turn up to assess you, and they may treat you on scene. So they're, you know, our paramedics, some of our paramedics are prescribers. They're able to, you know, prescribe certain medication. They're able to do certain things on scene. That means that they do not need to go to an emergency room department. The other aspect of that is the hear and treat. So our hear and treat is there may be a call coming in that will go to a clinician, and that clinician will assess that and then decide, okay, this is your treatment that we're going to offer you. But it may not be a response.
That's amazing. Yeah.
So
Brian, I've heard you talk a lot over the years about what this then can save in terms of your resources, right? Like you're not sending out that really expensive fire truck or ambulance or all those crews all the time. What do you see as being the biggest impact then there?
So when we implemented ECNS and the Omega protocols for our department, our goal was to drop our ambulance and what I would call heavy, an engine, response by about 11 to 18%. 18% would be the max. We figured that would be about $20,000 in fuel per year just for the heavies. Because, you know, again, people don't understand. You see those big red fire trucks, they get 2 to 4 miles per gallon, right? They're not getting 18, 20, 11, 10.
Yeah.
And so the other thing, and again, a fire service mantra, as it will, is to keep those heavies in service in their first in fire district. So if someone's house catches on fire, you've got an engine 4 minutes away or less. The fire department is not making financial gain other than its, you know, avoidance costs, right? Where by not sending out, by keeping people available, you have all those downstream impacts. But it's also a struggle because if you don't have 24-hour alternative care, like Instacares or doctor boxes, these clinics, freestanding clinics, in most cities close at 10 o'clock or 10:30. And so from 10:30 on, you have a normal process of an ambulance to an ER. What we found in my city, and others have found similar, about half the calls that would be eligible for this alternative stuff that Lou was talking about happen after 9 p.m. So half of the time, half of the calls that I could gain the benefits, I can't use because I don't have resources, the doors are closed, right? And if you are an ambulance service and you're not getting a benefit for the 911 system sending your caller to a nurse or an Uber drive to an Instacare, then that's directly hitting your bottom line. Now, we, at least for my city, I can't speak for anyone else, but in our city, we realized that the people that are using ambulances for a gout pain in their left toe at 2 o'clock in the morning are not full pay passengers anyway. They're going to pay a highly reduced rate if they're not just self-pay. So you're weighing the odds and the benefits. For our system, there was no benefit for us to do it other than maybe keeping resources more available. In the UK, when they have all the system is together in one ball of yarn, and which string you pull on, right? There's significant benefit there, but they've also spent a lot of resources and time to create those interconnecting elements, the non-emergent 111 line to the 999 line to single resource vehicles with one paramedic, advanced practice paramedic going out that can do certain things, or all these things are connected. And in most systems in the US, we don't have those interconnectivity that the 911 system has access to. Mm-hmm. You may have one or two where you are, I may have one or two or three where I'm at, but until we make some progress in our system, I think Party Dispatch and Party Solutions are making good headway with the new CPSS, another different advice line that Conrad Fivas and PSI have created, but it's going to take some time to perfect that and get it into wide production. But I think that's the direction we're going to go. Mm-hmm. They're being forced because of the extreme demand on their system. Their systems used to have many more ambulance services and dispatch centers, but they've amalgamated down to a lower number, which means the volume per center now rises. Mm-hmm. And they're still seeing 18% increase in that, and that is unheard of. Yeah. That is a dramatic number.
So Lou, talk a little bit about, we talked about the benefits, right, of kind of rolling out this model and making that evolution over time. What were some of the risks that maybe you ran into or challenges that you remember from that you really had to tackle and overcome during that whole process?
I mean, I think with any healthcare system, there are always going to be risks that you need to look at and try and mitigate those risks. I do think sometimes there is an element of risk that you need to run with. And I think when you're trying to manage that excessive workload, you need to look at where that risk lies. And I think really it's about doing the best for most. And I think it's also because that you're looking at those alternative care pathways those alternative care pathways may not be 24/7 themselves. Right. So that's, sometimes as Brian alluded to, sometimes that clinic might shut at 9 p.m. So then you're putting those types of calls back into that emergency system. So again, that's a risk. Yeah. For us in the UK, our biggest risk is our handover times because we're queuing outside of hospitals so we can offload our patients. And that's just because we're an extremely busy healthcare system. Right. And so what we're then trying to do is manage that risk with your clinical desks and, trying to explore different areas to provide that healthcare for that patient, really. What we provide comes with risks. And I do think that the ambulance services will decide where that risk lies. Yeah. Obviously, if you're waiting a long time for a response, then that's very frustrating for members of the public. But we really need to educate our members of the public on, was that really an emergency call? Right. There are there's the 111 system. There's other areas that you can reach out to explore for yourselves that level of care. And I think that comes down to, I talked about technology before, but there's so much technology now everywhere. And obviously with AI, and everybody has instant access to everything. I think we live in, we currently live where there is that expectation that everything needs to be instant. And I think as a society, we're more reactive because we can just Google something or chat GPT something and it's going to tell us this, and then we're reacting to what that's telling us. So I think as society we have become more reactive rather than trying to solve the problems.
The way I see it, I think to do nothing or to make no change and to continue just business as usual because of the fear of any of those risks that you talk about might be the biggest risk of all, right? To not change and not evolve and not look at alternative ways to provide that care to your citizens would have to be the biggest risk, right? Yeah.
There's an old saying that says evolution is the best defense against extinction.
I like it. We all live that one, right?
One thing that Louise talked about, which I think some people may not understand, is you can put 10 ambulances or 20 ambulances on the street, and you can take patients to the hospital, to the casualty department, what we call the emergency room. But if there's not a care provider inside the emergency room, they cannot take the patient inside. They can't just dump the patient without a care provider. So some agencies call it ramping or ramp time, where you have 5 or 6 ambulances sitting in an ER parking area with their engines running with patients in the back. And just by putting more paramedics in the street doesn't solve the problem, because it just creates a block somewhere else downstream from that event. So again, that's the impetus, to have them not transported by ambulance and not show up at an emergency room or a casualty room, because that's just another part of the problem.
Yep.
Opening up other streams of home care, in-home care, or a single provider going, those are the kind of things that everybody's exploring now, but in the UK they're doing it, I think, with greater frequency, with higher numbers than we could ever do here in the US. And hopefully we learn from what you guys have started.
Yeah. Yeah, and I mean, like I said, to make no change would be the most dangerous risk of all, All right, so Lou, as we kind of close this out today, because this has all been very, very helpful and just, so interesting to learn and see the different perspectives from both sides of the pond, as we say, right? What would be, for any of our listeners that are maybe looking at this today as either an exact same challenge that they're dealing with or something similar, what would be your advice to them with your vast knowledge, and you were in the trenches all of these years, doing the hard work? What would be your single piece of advice to them for how to get started?
So, I mean, it's a journey, and, emergency services or agencies need to look at what that journey means for them and what they have available to them, because it's not just about, what resources you have, it's about what referral pathways are available, which Brian's already kind of mentioned. I think it's also about research, evidence-based data. You need to really be looking at what your data is telling you and how you can use that data, because it's so powerful to help with that evolution. And I think it's, do not be afraid of the change. Embrace the change.
Embrace the change.
Evolution is the best defense against extinction.
I don't think I could say it any better than that, right? I mean, that's what it all comes down to.
Everything we're talking about puts a load on the dispatch center. It puts a load on the responders, but it also highlights the importance of what the emergency dispatcher does. Compliance, getting an accurate code that allows then agencies, and I've seen many agencies, sick person, everybody's favorite call, sick person. I have an earache, I have a toothache, and there's a code for that. And then many agencies don't use it. It's a 26 alpha 1. No, it's a 26 alpha 9. Then you can track how many of those patients had bad outcomes or were transported or whatever the case may be, to get the specificity that you need to do this correctly. So the dispatcher plays an extremely important role in getting this done correctly.
All right.
Can I add one more thing? One of the things that we are doing, and it is kind of throughout COVID and post-COVID, is virtual wards. So what we have is we have patients that are being, previously they would have gone into hospital, okay, and they would have taken up a bed. But now what they're doing is they're being managed at home on a virtual ward. So they have systems in place that will monitor their observations.
And just kind of
check in on them and see how they're doing, and they're being treated in their home rather than going into hospital.
That's
so
incredible.
Those virtual wards are, they're preventing the backlog and the bed blockers in the hospitals, which then helps us with our handovers and the management of those patients at home.
One of the things that Priority Dispatch and the Academy did is we put something in the protocol just for the UK, because in these home wards they have pulse oximetry. And they're told, if your pulse oximetry block drops below X, call 999.
Yeah.
And then in their version, I have my pulse oximetry and it says it's at 90, then that will change the level of response that they get. So even in the home care ward, the emergency dispatcher plays into that by having that in our protocol system that says this equals this and this equals, oh my gosh, this is worse.
Right.
So the dispatcher is still playing into, even in the home wards are playing into.
Sure. but you're empowering the actual patient to kind of triage themselves a little bit, which to me, that's the ultimate evolution, where we someday, cross our fingers, get to a point where people understand what really is that true emergency that needs a resource.
I won't hold my breath, though.
And treatment is better at home.
I can't tell you how many family members I've, accompanied at the emergency room because they needed to go there. And the first thing that they start saying when they get admitted is, I want to go home, right? Like, that's human nature. You don't really want to be at the hospital. Yeah. Well, thanks so much for joining me again today. I've learned so much from both of you, as I always do. It's been a pleasure, and I know that our listeners will just be so thrilled to hear about what this experience has been like, and kind of what they can take away for how to evolve this. And I know that we're still going to see so many. I mean, I can't even wrap my brain around what is going to be ahead for the changes. So thanks for coming and telling us about what it's been like for both of you and your amazing careers so far.
Okay.
Thank you.
Thanks, Meredith.
Thank you.
Thanks for tuning in. If you enjoyed the show, give us a 5-star rating wherever you get your podcasts. Be sure to let us know what you liked, and subscribe and follow us on Instagram and Facebook. Look for @TellMeExactly to get the latest on all things emergency communications. Tell Me Exactly is a Priority Dispatch Corporation podcast developed by our team of protocol experts and hosted by me, Meredith Jensen, with Cody Ekman as producer, Reading Roberts as sound engineer, Scott Robinson and Jason Barber as executive producers.